students. So today we are going to discuss about the questions of physiology in INI-CET 2020 November, right? So starting off with the first question, which of the following statements are correct regarding the mechanism of, yes, action potential, depolarization, repolarization and hyperpolarization in skeletal muscle, right? So what we can say in this is that we know this is very a simple question, right? So the answer of this question is multiple choice. This is a multiple choice question. So the answer is A. Depolarization is due to sodium through voltage gated. Obviously the sodium channels over here, they are voltage gated channels, right? What else? The repolarization is because of the efflux of potassium, right? And that too voltage gated. So C is also correct. And the hyperpolarization is due to, again, continuous efflux of the potassium. So answer over here is option A, C and E. Let's look at the diagram once, so it will be very clear. Okay, so this is the action potential in the skeletal muscle, right? What we can see over here is that the RMP is shown, right? And next to that, which phase is this? Over here, the depolarization is started, right? But the spike potential is yet not reached, right? That means the maximum amount of sodium channels, they are not yet open, right? As soon as it reaches to the threshold, this one, right? Maximum number of sodium channels, they will open up. And what will happen? The sodium channel, as soon as they open up, that means they opened because of the threshold, that is the voltage, right? And that's why the voltage gated sodium channel, they open up and causes depolarization. Polarization means negativity, right? Which is maintained in the RMP. More negativity, that is repolarization or hyperpolarization, you can say, right? Repolarization means coming towards back to the RMP, that is negativity. Depolarization means away from the negativity, right? Sodium channels are open up. Sodium is more outside of the cell, which is coming inside, making cell more positive, and that's why we get depolarization. And that happens because of the voltage gated channel, right? There is no ligand per se to bind on the receptor. They are activated because of the voltage. Fine, this happens. What happens at this level? This is a spike potential, right? This level is the spike potential. Once we reach the spike potential, what happens to the AP? The sodium channel will inactivate. Why? Because there is a closure of the inactivation gate of the sodium. And as soon as it closes, what happens? Which ions will, the channels of which ions open up? Potassium, right? So that is also because of the, yes, voltage again. So voltage gated potassium channel, they open up, right? And that's why what happened over here is that, yes, potassium is more inside the cell, right? Which is going out, right? Because of the concentration gradient as soon as the channel open ups. So what happened? Positive ion leaving the cell become, again, it is going back towards the negativity, that is repolarization occur. Now, the thing is to remember over here that potassium channels, they are slow to open and slow to close. So, even at the point where the RMP is reached, still the potassium channel is unable to close off, right? So, still the potassium is going out of the cell, right? Even the RMP is already reached. But now, the more and more potassium leaving the cell become more negative even further to the RMP. So that is nothing but the hyperpolarization, and that is because of the same voltage gated potassium channel that will remain open even after RMP is reached, right? So that's why the answer of this question is option A, C and E. Everything, these options are correct, right? Okay. Let's move on to the next question. True statement regarding skeletal muscle contraction. Again, over here, what we should know for answering this question is the EC coupling. What is that? Excitation, contraction, coupling. The answer over here of this question is yes. Option C. Let's see what happens and how happens in the excitation, contraction, coupling, right? Okay. So, first of all, we'll talk about the excitation. What happens in the excitation? In the excitation, what happens is that first thing, excitation. Once the nerve is stimulated, right, what will happen and how this is going to get stimulate any stimulus, any change in the environment that is going to stimulate a nerve, which will produce the action potential. How? Via releasing the acetylcholine. Let's take any neurotransmitter, let's take acetylcholine, right? After the stimulus, acetylcholine will be released via exocytosis from the presynaptic membrane, right? And that is going to go and attach to the motor end plate, right, in the skeletal muscle. That is postsynaptic membrane, right, wherever the receptors are available, right? Once it is attached, that means the ligand is attached to the receptor. What is going to happen? The action potential is going to get generated in the muscle, right? So, there is a generation of action potential. Now, how this action potential is actually generated, that we saw, that is nothing but the excitation. Now, the electrical phenomena, this is the excitation is electrical phenomena, which is followed by mechanical phenomena, which is nothing but the contraction. How this action potential will lead to the contraction, how this electrical phenomena will lead to mechanical phenomena. Let's discuss in a short manner and then we will see the diagram. Okay, let's see the diagram first, so it will be very easy to understand though. Okay, so what we said, that there is an axon terminal, that is nothing but the presynaptic membrane, right? The stimulus came to the nerve got depolarized, and which lead to release of the acetylcholine because of opening of the voltage gated calcium channels, right? So that is nothing but the excitation, and exocytosis occurred over here, right, which got released, the acetylcholine got released and it came through the synapse towards the postsynaptic membrane. The action potential is generated. Now this action potential will travel down to a receptor which is present on the muscle membrane or sarcolemmal membrane, and this tubule is known as T-tubule. The second one is known as T-tubules, right? The first one, they are the acetylcholine vesicles. Over here, what they shown is the T-tubule, right? This tubular structure is known as T-tubule. Now, over T-tubule, there are some receptor which is known as DHP. DHP, dihydropyridine receptors, are present on the T-tubule. What happens? This action potential will stimulate the DHP, right? What is the role of DHP? DHP is mechanically, remember, mechanically attached to the RYR, that is ryanodine receptors on the sarcoplasmic reticulum. So there are two channels, right? One is the DHP, which is voltage gated, and that's why it got activated or stimulated because of the action potential, right? Because it's a voltage gated, and this is mechanically attached to the ryanodine receptors. So ryanodine is activated mechanically, right? And that will open up. So once this action potential reach to, the red one is the action potential, once it reaches to the DHP receptors, right, that will open up the fourth receptor, that is ryanodine receptor. Inside, the calcium is there, right? Sarcoplasmic reticulum it has the calcium. The calcium will come out in the cytoplasm, right? And once it come out, what will happen? We know the calcium will attach to the troponin, which will remove the tropomyosin from the actin, right? So the active site of actin is open up, right? When there is a relaxation, the tropomyosin sits on the active site of actin, which is now not there, right? The tropomyosin detaches from the active site of actin molecules, and now the active site, since it is open up, the myosin head will attach to the active site, and which will form the cross bridges. Once the cross bridges are formed, over here you can see that the head is attached to the active site of actin molecule. This one is the actin molecule, and this one thick filament is the myosin molecule filament, which is having the heads, right, which is attached to the active site of actin. Now the cross bridges are formed, right? The neck will be tilted and the contraction will occur, right? So this is nothing but the excitation, contraction, coupling. So if we have to write it in a short manner, how we can write it? Okay, so we know that action potential is generated, right? And once the action potential is generated, what will happen? Which channels will be activated? This action potential will travel down or propagate towards T-tubule, right? Towards T-tubule. Over there, the DHP receptor, dihydropyridine receptors, are present already. They get stimulated, right? Which are attached to, and these are voltage gated, remember. These channels are voltage gated. These are mechanically attached to RYR or ryanodine receptor. Ryanodine receptor. Now, once this ryanodine receptor is opened up, right, this ryanodine receptors, they are ligand gated. No voltage came over there, so that's why they are ligand gated. In some books, it is written that both type of ryanodine receptors are present in the skeletal muscle, but most commonly over 90% there are ligand gated channel, and over 8 to 10% there are voltage gated channels. But then also the ligand gated ryanodine receptors are more, right, a lot more. So mainly they are ligand gated. So once they are open up, what will happen? They are present on the sarcoplasmic reticulum, right? And sarcoplasmic reticulum, it's nothing but the storehouse of calcium. So once they are open up, what will happen? There will be release of calcium, right? So calcium release from sarcoplasmic reticulum. And once it is released, what is going to happen? Yes, obviously this calcium will go and bind to troponin. This will bind to troponin, and that will because of this binding, what will happen? Calcium and troponin, the tropomyosin will detach from active site of actin filament, and and that's why once the active site is free, what is going to happen? There is a attachment of myosin head and active site of actin, which is known as cross bridge formation, and hence what will happen? The next, once the cross bridges are formed, tilting of myosin head will occur, and that's why the contraction will take place, right? So this is nothing but the excitation, contraction coupling, right? Fine. The only thing is to remember over here is that the voltage gated channel, they do not cause the calcium influx. This is already asked in one of the AIIMS exam, so that is a note that voltage gated channels, they do not cause calcium influx, right, except only found in, this is the exception, right, this is the exception which are only found in the skeletal muscle. Right, these calcium channel do not cause the calcium influx, and this is the one of the major exception, right? This is already asked in the AIIMS exam as a assertion and reasoning question, right? Okay, so the answer of this question is obviously sarcoplasmic reticulum. Option A is extracellular calcium is not important for contraction. No, there will be changes as the gradient change over is present, right? Why? Because if the hypocalcemia is there, what is going to happen? The calcium is not able to come inside, right? So there will be definitely the effect on excitation contraction, right? The sodium will not, sodium cannot go outside, right? And sodium will stuck inside. Why? Because less calcium inside the blood, and there is an exchanger which is sodium calcium exchanger which will not work. Sodium will build up inside the cell and which will lead to a depolarization, right? That can happen. So extracellular calcium is definitely important. Now, the calcium releases from mitochondria? No, the option B is wrong because it is going to release from the sarcoplasmic reticulum. Option D is voltage gated calcium channel on sarcolemma has no role in excitation contraction coupling. Obviously, it is having a role, and that's why it is mechanically attached to the sarcoplasmic reticulum ryanodine receptors, right? If that is not open up, the mechanically attached ryanodine receptor, they are not going to open up, right? So whole excitation contraction coupling will fail. So that's why they also do have a role in this. So answer is option C. Let's move on to the third question. What is third question? Posture changes there from supine to standing. What will happen? The answer over here of this question is option B, right? There will be decrease in the firing from baroreceptor, right? Now, baroreceptor, they are nothing but the brakes to the blood pressure. What happens once you change the posture from supine to standing? In this postural change, what happens is, once you stand up, the gravity will act on the blood, and what is going to happen? The blood is going to pulled in the capacitance vessels of the lower extremities, right? So there will be pulling of blood. In the capacitance vessels of lower extremities, right? Now, because of that, what will happen is that the blood will stay inside the lower extremities. So there will be decrease in the venous return, right? If the venous return is decreased, what will happen to the cardiac output? That is also going to go down, right? Once the cardiac output decrease, what is going to happen to the BP? The blood pressure is also going to decrease, right? Once the blood pressure is decreased, what is happen the next? There will be vasoconstriction to the arterioles which are supplying to the baroreceptors. Remember, if the blood pressure is low, then what will happen? There will be vasoconstriction which is seen in the arterioles supplying to the baroreceptors. Now, because of this, what will happen to the firing rate of the baroreceptors? Obviously, there is less blood supply, so that means the blood pressure is reduced, and that's why they decrease the firing rate. So there will be decrease in the firing from the baroreceptors, right, which are located in carotid sinus and aortic arch. Carotid sinus and aortic arch, right? Now remember, this change in the cardiac output is there and the blood pressure is going down a little bit. There is an effect on the splanchnic circulation. It is seen that yes, there is effect on the splanchnic circulation. They cause a little bit of vasoconstriction unless and until the BP get back to normal, right? All the compensatory mechanisms are activated. Till that, the splanchnic circulation is definitely having an effect or role, but not the mesenteric. Mesenteric is not having much of a role, so that's why the mesenteric vasoconstriction is usually not seen, right? The vagal output to the cardiac fiber, which is option C, is actually decreased. Why? Already BP is low, and that's why parasympathetic will go down, right? It will not increase, right? And so that's why the answer of this question is option B. Okay, let's move on to the fourth question. Question number 4 is saying we have to identify which conditions are shown in the figure A and D. Now, first of all, don't get scared after looking this diagram. It's a very easy diagram. What it is showing over here, let's have a look. Over here, they are showing the blood pH, right? So normal is 7.35 to 7.45, right? So this level is normal. Now, what is happening in the A and D? Remember, both are A and D, both are acidosis, right? Why? The pH is low. The pH is low, right? Simple. One thing is sorted out, that both are acidosis. Now, look at the y-axis. Over here, they are showing the bicarb levels. Now, the bicarb in the D option is low, right? Low bicarb. Okay, that means it is a metabolic acidosis, right? The D is metabolic acidosis. The answer must be A, B or no, A or D. Why? Because both are acidosis. Now, obviously, the answer becomes respiratory acidosis. There is a reason also, but to exclude, solve this question by the exclusion. Acute or chronic, how to know that thing? If there is an acute, there is no time for compensation, remember that, right? If it is a chronic, there is a time for compensation. So let's see why it is respiratory first thing first. Now, the A, in that the bicarb levels are normal. In the A, approximately normal, right? But look at the PCO2. These red lines are showing the PCO2 values, right? The red lines are showing over here. These are showing the PCO2 values, right? Let's have a look. In the D option, the PCO2 value is, yes, normal. But in the A, what is the PCO2 value? Remember, it is 80 to 90. Usually it is between 40 to 45, but over here it is increased. And obviously we know that once the PCO2 increase, that means it is a type of which acidosis? It is a type of respiratory acidosis, right? So answer of this question over here is option A. Option A, right? Let's see a similar diagram if we have that, right, over here. See. The diagram we're showing the PCO2 also, over here it is not shown, only one line is shown, right? That is what we require. If the PCO2 over here is shifted toward left, that means it is increasing, right? So, metabolic acidosis. What happens in the metabolic acidosis? Its acidosis means the pH will be low, right? The bicarb will be low too, right? So, what should be the approach? The approach should be, first of all, have a look at the pH, whether it is increase or decrease. If it is increased, that means it is alkalosis. If it is decreased, that means it is acidosis, right? Then have a look on the bicarb, right? If the bicarb is normal, that means it is respiratory. If the bicarb is low, that means, yes, it is acidosis, that too metabolic. And if it is increased, that means whether it is trying to compensate the respiratory or it can be alkalosis, right? After that, have a look on the PCO2. If it is increased, that means it is the respiratory acidosis, and if it is decreased, right, that means whether either it can be trying to compensate for the metabolic acidosis, or yes, it can be alkalosis. Now, how to deduce the results, that conclusion, that whether it is trying to compensate or it is the alkalosis? Very simple, coordinate with the pH, right? If it is correlating with the pH, that means it is the alkalosis, it's not the compensation, right? But it is going in the opposite direction, that of the pH, that means it is, yes, compensatory effect on the another system, right? Fine. The same diagram, similar diagram is shown over here. So, A was metabolic acidosis, the A was chronic respiratory acidosis and D is metabolic acidosis, right? The PCO2 values, that is increased, right, in the format A, right? Okay. So, over here in the A, the PCO2 values are much more, right? But if you see the bicarb, bicarb value over here, that is also increased, but it is not the pH which also increases, right? The bicarb levels are normally 18 to 24, but if you see over here, if you see in this diagram, in the A format, what is happening? The bicarb levels reach to 40. That means it is trying to compensate, and that's why it is not acute, it's a chronic one, right? And that's why the bicarb levels are increased. In the acute condition, what happens is that there is no time which is pursued for the compensation, and that's why the bicarb levels will be either normal, right, or slightly increased, not reaching to the 40, right? So that's why the answer is chronic respiratory acidosis. So that's why the answer is option A. Okay. Let's move on to the next question, that is regarding the, yes, membranous receptors, transmembranous part of the receptors contain which type of amino acid? Very easy. It is amphipathic. It is amphipathic, means it is containing both the types, right? Let's see a diagram. Okay, here is it. So, it's very easy diagram. You can easily understand that. We do have a lipid bilayer membrane. right? So we do have lipid bilayer membrane, right? And if it is a lipid, that means the water soluble molecules, they cannot be integrated inside the lipid bilayer, right? So that's why the molecule, the protein part which is indented into the lipid bilayer, that is hydrophobic. It's a hydrophobic, right? And outside, we say that 60 to 70% of our body fluids are containing the water, right? And outside of this lipid bilayer, what is going to happen? Even inside the cell or outside the cell, there will be water, right? And that's why the protein which is facing towards the inside the cell or outside the cell towards the water, right, it will be water loving, that means hydrophilic sides of the chain, right? Over here also you can see that there are different various types of the receptors. So there are hydrophobic and hydrophilic, both are present, so they are showing actually the amphipathic nature. So what we can write? The transmembrane proteins, they are amphipathic in nature. That means they do have both the parts, hydrophilic and hydrophobic. Both the part, hydrophilic as well as hydrophobic. The hydrophobic ends pass through the membrane and interact with whom? And interact with hydrophilic tails and also hydrophilic tails of lipid molecule in lipid bilayer, right? And they get sequestrated. And they get sequestered away from the water, obviously, right? They get sequestered away from the water. So phobic ends, they pass through the membrane and meet to the hydrophilic tails, and that's why get sequestered away from the. And phobic means away from whom? Hydro, that means water, right? While the hydrophilic, what will happen to them? Hydrophilic regions, they are exposed towards the water, right, on either side or both the sides, right, of the membrane, right. So that is nothing but the hydrophilic and hydrophobic parts of the transmembrane protein. That means they are amphipathic, and that's why the answer of this question is option A. Okay, let's move on to the next question. Question number 6. Which of the following increases in COPD? Right? Obstructive pulmonary disease, chronic obstructive pulmonary disease. The answer over here is option A. Why answer is A? Let's see that. First of all, we should be knowing that what is chronic obstructive pulmonary disease. Now, it contains two things. What is that? First thing is bronchitis or chronic bronchitis, usually seen in the smokers, right? In bronchitis large, it is chronic bronchitis, so mucus production is increased, right? Is too much. And another is emphysema. Another is emphysema. Now, if we want to see all these things, what we can see over here is that there are some, we done a spirometry, what we get is this, right? The TV, IRV and ERV and RV, if we sum two or more values, we get the capacities. What is important capacity over here is number 6. What is that? That is nothing but the FRC value, this much. That means whatever air remain inside the lung after a expiration without any force, right? You do not apply any force, you are in the resting condition. If you expire, whatever amount of air is inside, remains inside the lung, that is FRC, that is nothing but the RV plus ERV, right? That is important. Why it is important? Because there are only two types of lung diseases, majoritarily, when we talk about two types of diseases, what is that? One is the obstructive and another one is the restrictive, right? What is important is FRC, right? But there is a ratio which is known as FEV1 upon FVC, right? Or you can say FRC, also one and the same thing, right? What is this FEV1? FEV1 is the forced expiratory volume during first second, right? So how much amount of air a patient or a person or a subject can expire as harder, as quickly as possible, right? So that is nothing but the FEV1. Remember, over here there is an obstruction, right? So what is going to happen if there is an obstruction? The subject will not be able to expire much of air in 1 second, right? Slowly he can expire air that is available inside his lung, but in 1 second he cannot expire as a normal person. Why? Because there is an obstruction, and obstruction are usually in the airways, right? So what will happen to the FEV1 value? If we talk about FEV1, that is going to be decrease, right? But in the lung parenchyma per se there is no disease, right? So FVC will be normal, right? Numerator is decrease and denominator is normal, so that's why the ratio going to get decrease, right? This happens in the obstruction. What happens in the restrictive diseases, such as let's take fibrosis or any interstitial lung disease? What will happen in that is that there is a problem in the lung parenchyma per se, right? So, but there is no problem in the airways. So FEV1 will be normal and the FVC will be decreased, right? The forced vital capacity will be, or forced residual capacity will be reduced. Why? Because the parenchyma is diseased, it got fibrosed, right? It cannot contain any air, it cannot take any air inside, so the FVC will decrease. Over here what happened? The denominator is decreased and the numerator is almost normal, right? In the severe condition the FEV1 is slightly decreased too, but over here what we are looking at is the simple condition, right? So what will happen if the denominator is decreased and the numerator is almost normal? So the ratio will either increase or normal, right? That depends on the severity of the condition, right? So in restrictive, the ratio of FEV1 upon FVC will be normal. In the obstructive, it is going to get decreased. And the emphysema, chronic obstructive pulmonary disease, right? So what is going to happen to the ratio? Ratio is going to decrease, right? And what they ask is what is going to increase, right? So in the obstruction, what happens is, in some of the condition, the obstruction is so much in the severe conditions that full air cannot come out. In condition of emphysema, what happened over there is chronic obstructive pulmonary disease is also containing the emphysema. So what happens in the emphysema is that the elastins fiber, there is much of elastase, so they are broken down. If the parenchyma is easily get stretched up, the compliance over here is increased and the elasticity is decreased. Due to loss of elastin fibers, the elasticity is decreased. If the elasticity is decreased, remember what happened in the normal expiration. I'm not talking about the forceful expiration. The normal expiration is passive process, right? It is because of the recoil process, recoil of the lung parenchyma, right? Or recoil of the alveoli. If the elasticity is decreased, the recoil will be decreased too, and that's why the residual volume will increase, or you can say the FRC will increase too, right? The FRC will increase too, and that's why the answer over here is FRC, right? Okay. All other volumes, they are not actually increase, they rather decrease or will be normal depending on the severity of the patient, but they never increase in obstructive lung diseases. Okay. Let's move on to the next question. Question number 7, that is least frequency of BER is seen in. The answer over here is option D. Option D. Stomach. What is this BER and how it is related to the GIT? Let's see. The BER, first thing first, is nothing but the spontaneous, you can say, depolarization and repolarization. So it is nothing but spontaneous depolarization and repolarization right, of what cells? Of the pacemaker cells of GIT, that is nothing but the interstitial cells of Cajal. It's a Spanish name, so you have to pronounce it as Cajal, right? Interstitial cells of Cajal, or it is also written as, right? Fine. So because of this, what happens that these cells are present where? Inside the, in smooth muscles, in the smooth muscles of GIT, right? Not the whole GIT, the esophagus and the upper portion of, proximal portion of the stomach is, they are not having these pacemaker cells, right? So where they are present? They are not present everywhere. The distal part of the stomach, right? The small intestine and the large intestine. This is going to have this smooth muscle of these cells. They are going to have the interstitial cells of Cajal. Now these pacemaker cells of Cajal, right, or interstitial cells of Cajal, they are going to produce they are going to produce the electrical activity, right? Because the mechanical activity will follow the electrical activity always. So they are going to produce the electrical activity, which is known as basal electrical rhythm. Basal electrical rhythm. They are nothing but the cyclic fluctuation in RMP, right? This basic electrical rhythm is nothing but the, in one sentence, they are cyclic fluctuation in resting membrane potential, right? RMP. One thing very important, the BER alone, remember, always remember, they cannot produce the contraction, right? They are alone. If they are alone, there will be no contraction, right? Or you can say the smooth muscle fail to contract if the BER alone is there, right? So how the contraction occurs in these smooth muscles, remember, you need to stimulate these. So BER plus stimulus, if you give the stimulus, what is going to happen? There will be production of spike potential. Once the spike potential is produced, the calcium influx will occur, right? Once the calcium influx occur, the contraction will take place, right? Okay. So what are the frequencies of these BER? So organ, and you can write BER frequency, right? Okay. First of all, stomach. Stomach, they do have 4 per minute BER, right? Duodenum, they have maximum approximately till 12 per minute, right? The small intestine, rest part, jejunum and ileum, they do have a range 9 to 10 per minute. 9 to 10 per minute. Then the sigmoid colon, also the rectum, they have approximately, it is having the largest range, that is 6 to 16 per minute. 6 to 16 per minute, right? So if we have the diagram, let's see. Okay, fine. So over here you can see this, the stomach is having 3 to 4 per minute, right? The Ganong says 4 per minute. Then the duodenum, they are having 12. The small intestine rest part, the jejunum and ileum, they are showing 9 to 10 per minute. And the rest part is showing a large amount of range, 6 to 16, 8 is shown over here, right? Okay. So we know that the stomach is having the least amount of BER, right? So the answer is option D. Let's move to the question number 8. Okay. Increased concentration in PCT is seen in which of the following? Now we are talking about the concentration in PCT. That means that substance which is going to get reabsorbed the least, that is going to have a maximum concentration in PCT, right? So, okay, we do have the diagram for this also. So over here you can see that PCT absorb many things. Important ones are the glucose and amino acid. The glucose and amino acid. Then the bicarb is there, which is absorbed almost 85 to 90%. And the sodium and chloride, they absorb almost 60 to 65%, right? So what we said recently that if the substance is getting reabsorbed, so reabsorption is inversely proportional to PCT concentration. Of that particular substance or molecule, right? If the substance got reabsorbed, that is going to go inside the blood and will not remain inside the PCT, right? So that's why it is inversely proportional. So what is the rate of absorption? How much percentage of each substance is absorbed? So remember, glucose, it is reabsorbed 100%. Almost 100% unless and until the transporter are saturated, right? Or it is exceeding the T max value, but it is not anything, such things are not written in the question, so we are taking it as 100%. Amino acid, same, right? Almost 100%. What about the bicarb? Approximately 85 to 90%. The reabsorption is 85 to 90%, right? What about the chloride? Sodium and chloride approximately 60 to 65%, right? And what we said? Least the absorption, more will be the concentration. So chloride are least reabsorbed. So more concentration, in the PCT, right? In the PCT, and these two are 100% reabsorbed. That means almost 0% PCT concentration will be there, right? So answer of this question is option C, chloride. Answer of this question is option C, chloride, right? Okay. Let's move on to the next question. Okay. The simple muscle twitch graph is given, right? And you should be knowing what is latent period, what is contraction period, and what is relaxation period in this case, right? So this is the time tracing, and if the time is not given, that means we recorded it with the help of vibrating tuning fork. Usually we use the 100 Hertz vibrating tuning fork. Usually we use 100 Hertz of vibrating tuning fork, right? The frequency is 100 Hertz. That means 100 times it gives the waves of per second, right? It vibrates 100 times per second. So that means the one wave is of 0.01 second, right? 0.01 second. So how many waves are there? Almost. So A to B, this is A to B. This is known as latent period, right? The B to C, this is known as contraction period, and C to D is the relaxation period. I hope everybody done this experiment in the PG, UG first year, right? So relaxation period. So we just have to calculate how much is the contraction period, right? So why? Because how the minimum titannizing frequency is calculated? is equal to 1 upon contraction period. 1 upon contraction period, right? So over here the contraction period is almost 5 waves. One can take 6 also, but 6 will give us 100 upon 6 you can take, so it will give us almost 16.6, but that is not an option. So we will take a 5, that is 1 upon minimum tetanizing frequency, 1 upon 0.05, right, seconds, right, because 1 will give us 0.01 second, right. So that will be equal to around 20, right. So 100 upon 5, that will give us 20 per second, right. So 1 upon contraction period is the minimum tetanizing frequency, which came out to be 20, right, which came out to be 20. If we would have taken it 6, it's something between 5 to 6. So if we would have taken it 6, the answer would have been 16.6, right, but there is no such option. So that's why the answer is option D, right, 20 per second. For that you should be knowing the formula, which is very easy formula, 1 upon contraction period, right. Okay, let's move on to the next question, that is sequence after P wave. For that you should be knowing to correlate, how to correlate the ECG, JVP, all the heart sounds and the electrocardiogram and the phonocardiogram also, right, all the waves, all the pressures, ventricular pressures and arterial pressures. So usually the P wave is followed by A wave in the JVP. Let's prove that too, right. Okay, so here is the diagram which is correlating each and every phases of JVP, all the pressures, echocardiogram and phonocardiogram, right. So over here that we can see the A wave of the JVP, right. So the dotted lines are showing the waves, JVP waves, right, and over here what you can see is the ECG, right, all the waves, P wave, Q wave, R, S and T, right, and the phonocardiogram is shown below. The first heart sound is this one, right. So you can see that P wave comes first, then the A wave and then the phonocardiogram S1 wave, right. So what is left? We are left with the rapid ventricular filling. Remember, whenever there is atrial systole, right, after that what happens is the slow ventricular filling, slow ventricular filling. That means what we can say is, first of all, there are 3 major phases, that is isovolumetric, contraction, isovolumetric contraction, then the rapid filling, right, and the A wave is there already. So that means the atrial systole is going on, and over here that you can see the rapid filling phase is already done, right. This is the ventricular filling which is showing the ventricular volume. The rapid filling phase is already gone before the P wave, right, and what remains is the slow filling, right, slow or active filling because of the atrial contraction. The rapid filling is the passive contraction, rapid ventricular filling rather, right, and rapid slow ventricular filling, right. So slow ventricular filling, that takes us take about one third time, right, and first 2/3 time is the passive filling. Then there is an active filling which is the slow filling. Active, why active? Because the atrial systole is there, means the muscle is contracting and filling the ventricles. That's why it is known as active, because the muscle working, right? The muscle is working over here. So that's why the rapid ventricular filling over here, we can justify that with this diagram, that there are volume is increased in two phases, right? We know that rapid filling and slow filling. First 2/3 is rapid filling. The rapid filling phase is done before almost the P wave is occurring. At that time it is almost finished, right? And this one, which is showing the 1/3 filling when the volume is increased, that is nothing but the slow ventricular filling, right? So the A wave comes after the P wave. The P wave is finished, almost there, the A wave is showing up, right? And the sound occurs after the A wave, right? So the first heart sound actually comes after the A wave. So the answer over here is option A. Answer over here is option A. So the A wave is showing the atrial systole, right? And this is of JVP, right? Jugular vein pressure wave, right? The first heart sound that is nothing but the S1. It comes after the A wave of JVP, after the A wave of JVP, right? And whenever there is a atrial systole or systole, so what happens? What is going on? That means the slow ventricular filling, slow and active, you can write, ventricular filling is going on. Slow active ventricular filling is going on. The rapid filling is already done, right? The rapid ventricular filling is already, this has already been occurred before P wave. Before P wave, right? What about the T wave? Obviously, which is very, very obvious, that T wave comes before P wave and too long after P wave, right? It comes before P wave. There is no other T wave instead of ECG, right? So comes before P wave, not after P wave, right? So that's why the answer over here is option A. Okay, let's move on to the next question. Calculate the respiratory quotient. When the patient weight is given 50 kg, okay, there is no relevance of this weight per se, okay. Still, the CO2 exhaled is 200 ml and the O2 consumed is 250 ml per minute, right? So we have to find out what is its respiratory quotient. So it's a very, very easy question if you know the formula of respiratory quotient. What is the formula for respiratory quotient? That is, the formula is CO2 released from the lung upon oxygen consumed by the body. So you can write CO2 released upon oxygen consumed by the body. That is what is the values given. The CO2 was 200, right, and the O2 was 250 ml per minute. That comes out to be around 0.8. That comes out to be around 0.8 ml per minute, right? So the answer is very, very easy. It is nothing but option A. The answer over here is option A. The weight is not having any per se relevance in this question, right? Okay, let's move on to the next question. Okay, the graph is given and they ask about the filterability. If you know a fact of sialoproteins or siloproteins, whatever you call, it is very, very easy to understand this graph, right? The filterability is given. A is more filterable than B than C, right? This is first thing first. A is more filterable than B than C if we talk in terms of filterability, right? What we have to know is the structural format of the nephron or the glomerular filtration membrane, right? Because we are talking about the kidney and filtration occurs at glomerular filtration membrane, right? So, what we are talking about over here is the glomerular filtration membrane. What about this membrane? What is so specific about it? So remember, there are 3 layers of this membrane. What is the first layer? The endothelial layer of the glomerular capillaries. So, what is the second layer? The second layer is the basement membrane, which is full of collagen and also important proteins, right? We will talk about that. And third layer is epithelial cells of Bowman's capsule. Right, Bowman's capsule. In that they contain podocytes, you can see that, and also with their food processes. Right, okay. Now this is the glomerular filtration membrane. Let's draw it quickly. In a simple manner. Suppose this is the glomerular capillary cells, endothelial cells, right? There are some pores which are larger than other capillaries, which is known as fenestration. So in them the fenestrations are present. Fenestrations are present, right? Then the basement membrane, let's draw that too. Simple collagen fibers are there, right? Collagen fibers are there, but not only the collagen fibers, but they also contain a specific proteins which are negatively charged, right? Which are negatively charged. Okay, so the basement membrane is also containing a protein which is known as sialoproteins, but they are, remember, they are negatively charged, right? So they are containing negatively charged protein which is known as sialoproteins. So if the sialoproteins are there, what is going to happen to the filtration when the negative charged particles is coming towards the basement membrane? They are going to repel them, right? So anionic particles, they are going to get repelled, right? Let's draw the epithelial layer also. So let's draw it with the black. So suppose this is the last layer of the epithelial cells and their podocytes. Obviously, we are not going to invest much of the time in the drawing, right? So suppose this is the third layer of the Bowman's capsule, right? which are containing the podocytes and their food processes. So what we talked about the basement membrane is that they are containing what thing? The basement membrane they are having the negatively charged protein particles, which are known as proteins inside the basement membrane. The important part is that they are negatively charged. Right? So if they are negatively charged, so what they are going to do? They are going to repel. They are going to repel and prevent the filtration of negatively charged particles, right? They are going to prevent the filtration of negatively charged particle. Obviously, negative repels negative, and they are make it easy to filter to the positively charged ion, which are known as cations, right? So what we are talking about here are the anions. So they are going to repel the anions, right? Okay, so charged particles, or you can write plasma proteins, mainly the plasma proteins, albumin, and that's why the albumin is not seen in the urine, right? So in short, if I have to say, the anions or anionic particles are less filterable. They are less filterable, right? Okay, so if we have to talk about the filtration, remember the filtration occur first thing first on the basis of size, 4 to 8 nanometers. Why? Because the pores are of this size, the fenestration are of this size. So whatever particles are coming in this through this glomerular capillaries, if there are 4 to 8 size, what will happen? It is important. Why? Because if the particle is less than 4 nanometer, it is going to get filtered very, very easily, right? If it is 4 to 8, we will talk about that, and if it is more than 8 nanometer like RBCs, WBCs, it is not going to get filtered, right? So if the particle is 4 to 8 nanometer, in between that, then what criteria should be there? The charge is the criteria, right? The first criteria was the size, then the charge. So it is going to get filtered on the basis of charge, right? So if two possibilities are there, negatively charged or positively charged, right? So negatively charged, they are not going to get filtered, they are going to get repelled, right? So not filtered. And positively charged, so get filtered easily, right? So that happens only because of this sialoproteins, which are there inside the basement membrane, right? So if we come back to this diagram, what we can say is that the A is easily filterable, right? It is more filterable. So if you see, the relative filterability is more, that means they should be cationic, right? So they should be cationic. B may be neutral, so it is less filterable than the A but more than the C, and C is anionic, right? So answer is A is cationic, B is neutral, C is polyanionic. So accordingly they ask, so answer is option A. The answer of question number 12 is option A. Okay, let's move on to the last but not the least question. Macula densa formed by which part? Remember, this is a part of DCT, distal convoluted tubule. The answer over here is B. The answer over here is option B. Let's see why. And if we have a diagram of this. Okay. So, this is the part of macula densa. So, over here you can see that this is the macula densa. This is the luminal cells which are in between the afferent arteriole and efferent arteriole, but they are the cells of distal tubule. Remember, the tubule which comes in between the afferent arteriole and efferent arteriole, but the epithelial cells which are there, which are known as macula densa, they are the cells of distal tubule. They are not the cells of arterioles, afferent or efferent, right? So, if we have to write it, the macula densa is also became one of the favorite topics of the examiners. So you should be knowing regarding the questions, but you should know that what are the functions of this macula densa also. So there are high probability or high chances that this question can come, or the questions on macula densa can come. So it's a part of distal convoluted tubule, right? What is the function? It regulates GFR. It regulates glomerular filtration rate. How? They have a specific property that they sense the GFR. How? How they sense the GFR? They actually sense the GFR by sodium and you can say chloride levels. They actually sense the sodium and chloride levels in tubular fluids. And via the sodium and chloride levels, they sense whether the GFR is normal, less or more, right? They not only sense that, but also correct it. If it is low or much more, they correct it. How? With the help of mesangial cells. By mesangial cells which are present around glomerular capillaries. And the whole process is known as tubuloglomerular feedback. This whole process is known as tubuloglomerular feedback, and in the short it is also known as TG feedback mechanism. TG feedback mechanism. So over here they ask about only the juxtaglomerular apparatus. So remember, this lumen is of DCT. That's a distal tubule. It's not the part of afferent or efferent arteriole. It actually came through the DCT itself, right? There is a coiling of DCT, and with that coiling to sense and regulate the GFR, this is the protective mechanism which is occurring over here, right? And this is the afferent, this is the efferent, and this is the lumen of these two, right? So the macula densa is a part of DCT which comes in between the afferent and efferent, but it is not at all a part of either efferent or afferent arteriole, right? So answer over here is option, yes, B, right? So that's all guys for the INI-CET question. Thank you.